Welcome. In this session, we will be discussing the anatomy of extraocular muscles and their associated structures, and in the next session, we will be discussing the function of extraocular muscles. So, we will be discussing the anatomy of ocular movements in this session, and we will discuss the physiology of ocular movements in the next session. Each eye has 7 extraocular muscles with 4 rectus muscles and 2 oblique muscles moving the eye, and the levator palpebris superioris muscle elevating the upper eyelid. It is important to note that the levator palpebris superioris muscle is also considered as an extraocular muscle. All 4 rectus muscles originate from the annulus of Zinn, a fibrous ring at the apex of the orbit. The annulus of Zinn straddles the optic canal and the superior orbital fissure. The lateral rectus muscle courses anteriorly and laterally along the lateral orbital wall, and the medial rectus muscle courses anteriorly and slightly medially along the medial orbital wall. Superior rectus muscle courses anteriorly, superiorly and laterally at an angle of 23 degrees to the visual axis in the primary position of the eye. So this angulation 23 degrees to the visual axis in the primary position of the eye is very important to remember. The primary position of the eyes is the position in which the eyes look straight ahead with the head erect, and in the primary position of the eyes the visual axis of the two eyes lie parallel to the coronal plane and the sagittal plane of the body. Similarly, the inferior rectus muscle courses anteriorly, inferiorly and laterally at an angle of 23 degrees to the visual axis in the primary position of the eye. The anteroposterior mid-orbital line passing from the orbital apex to the center of the anterior opening of the orbit is also oriented 23 degrees lateral to the sagittal plane of the body. All 4 rectus muscles insert anterior to the equator, and this is very important to understand the effect of the extraocular muscles on ocular rotations. So if this is the center of the globe, the equator lies along this plane, and the insertions of the rectus muscles all lie anterior to the equator of the globe, and the distances of insertions of the rectus muscles are in an ascending order, with the medial rectus insertion being nearest to the limbus 5.5 mm away from the limbus, then the inferior rectus insertion at 6.5 mm from the limbus, then we have the lateral rectus insertion at 6.9 mm from the limbus, and the superior rectus insertion is the furthest away from the limbus at 7.7 mm from the limbus. And this ascending order forms a spiral called the spiral of Tenon. The lateral portion of insertions of the superior and inferior rectus muscles are further away than their medial portions, and the sclera is the thinnest just posterior to the insertion of the rectus muscle and can be perforated during small recessions of the rectus muscle, and this is also very important to remember. The superior oblique muscle originates supranasal to the annulus of Zinn. It courses anteriorly and superiorly along the superomedial wall of the orbit. The superior oblique muscle becomes a tendon before reaching the trochlea, where it is redirected posteriorly. The trochlea is a cartilaginous structure attached to the periosteum of the frontal bone in the anterior part of the supranasal orbital wall. The trochlea acts like a pulley to redirect the tendon of the superior oblique posteriorly, laterally and inferiorly at an angle of 51 degrees to the visual axis in the primary position of the eye. So the trochlea acts as the functional origin of the superior oblique muscle. The tendon enters the Tenon's capsule 2 mm nasal and 5 mm posterior to the nasal end of the superior rectus insertion, and this is surgically important to find the tendon of the superior oblique muscle within the Tenon's capsule. The tendon then passes under the superior rectus muscle as shown in this diagram and inserts on the superotemporal portion of the eyeball behind the equator. So this is the posterior view showing the insertion of the superior oblique muscle after passing underneath the superior rectus muscle and closely related to the superotemporal vortex vein. the orientation 51 degrees to the visual axis in the primary position of the eye and the insertion behind the equator is important to remember. The inferior oblique muscle, whose origin is shown here in this diagram and the insertion is shown here in this diagram, originates from the maxillary bone of the anteromedial portion of the orbital floor, immediately posterior to the inferior orbital rim and lateral to the opening of the nasolacrimal canal. It courses posteriorly, laterally and superiorly at an angle of 51 degrees to the visual axis in the primary position of the eye, the same angle subtended by the superior oblique muscle to the primary visual axis. The inferior oblique muscle passes beneath the inferior rectus muscle as shown here in this diagram, and it inserts on the posterolateral portion of the globe near the macula, where it lies medial to the lateral rectus muscle. Infrequently, there can be two or more muscle bellies which need to be identified during surgery on the inferior oblique muscle, otherwise the effect of the surgery will be suboptimal. As we have discussed in the section on neuro-ophthalmology, the upper division of the third cranial nerve supplies the superior rectus and the levator palpebris superioris muscle, and the lower division of the third cranial nerve supplies the medial rectus, the inferior rectus and the inferior oblique muscle. The fourth cranial nerve supplies the superior oblique muscle, for which we have a very popular mnemonic SO4, and the sixth cranial nerve supplies the lateral rectus muscle, for which we also have a very popular mnemonic LR6. Nerve to the inferior oblique muscle supplies the inferior oblique muscle from its lateral aspect at half the distance from the origin of the inferior oblique muscle to the insertion of the inferior oblique muscle, where the inferior oblique muscle crosses below the inferior rectus muscle and where the inferior rectus pulley is situated. We will be discussing the pulley system in this session. The nerve to the inferior oblique can be easily damaged at this location during inferior oblique muscle surgery. The nerve to the inferior oblique also carries parasympathetic fibres to the pupil and the ciliary body, so injury to the nerve during surgery or otherwise may result in mydriasis and cycloplegia. The nerves to the four rectus muscles and the superior oblique muscle enter the respective muscles at 1/3 the distance from their origin near the orbital apex to their insertions, and the trochlea in case of the superior oblique muscle. And the entry point of these nerves in their respective muscles lie more than 25 mm posterior to the rectus muscle insertions. So dissections more than 25 mm posterior to the rectus muscle insertions can damage these nerves. The superior oblique is supplied from its outer surface and the four rectus muscles are supplied from their inner surface. We have already noted that the inferior oblique muscle is supplied from its lateral margin. The fourth cranial nerve lies outside the muscle cone and is thus least affected by a retrobulbar injection. However, any of the extraocular muscles can be injured during a retrobulbar injection. Each rectus muscle is surrounded by a fascia called its muscle capsule from its origin to its insertion, as represented by the yellow line in this diagram. The fascial capsule enables the muscle to glide smoothly against adjacent structures. The muscle with its fascial capsule enters the Tenon's capsule posterior to the equator, the blue line representing the Tenon's capsule. Anterior to the equator, the inner surface of the muscle lacks this fascial lining and instead have connective tissue attachments with the globe. And during surgery, minimizing injury to the muscle capsule reduces the chances of intraoperative bleeding and post-operative adhesions. Also, during surgical reattachment of the muscle to the globe, the suture should pass through the muscle fibers and not through the muscle capsule only, else the muscle will retract posteriorly within its muscle capsule, resulting in a slipped or lost muscle. The intermuscular septum, as represented by the dark blue area in this diagram, connects the fascial sheaths of the extraocular muscles. It extends from the middle of the orbit to the equator of the globe, where it fuses with the Tenon's fascia, as represented by the light blue area in this diagram. It separates the intraconal from the extraconal space, When a muscle is lost during surgery or after trauma, locating and tracing the intermuscular septum helps in finding the lost muscle by leading us to the lost muscle. Resection surgery, in which a muscle is disinserted from its insertion, shortened by resection, and then advanced and reinserted to its original insertion, requires adequate dissection of intermuscular septum to prevent excessive advancement of connective tissues anatomically connected with the muscle being resected. Dissection is also required for connective tissue frenulum between the lateral rectus and the inferior oblique, and also the connective tissue frenulum between the superior rectus and the superior oblique when the respective rectus muscles are operated upon. Tenon and intermuscular septum becomes thin with age, and thus adults require less dissection of these connective tissue elements as compared to children. The pulley system of the extraocular muscles are very important to understand. The superior oblique has a pulley at the trochlea which redirects it and acts as its functional origin, as we have already mentioned. Where the extraocular muscle enters the Tenon's capsule near the equator of the globe, the Tenon's capsule is thickened into sleeves around these extraocular muscles, and these sleeves are called pulleys. The pulleys are 10 to 20 mm in anteroposterior extent and are attached to the periorbita and other connective tissues adjacent to the muscle. They stabilize the course of the muscle and act as functional origins of the muscle. The entrance of the inferior oblique into the Tenon's capsule is common with that of the inferior rectus muscle. As seen here in this diagram, the common fascia of the two muscles form the Lockwood ligament, which we have extensively discussed in the session on anatomy of the eyelids, and this Lockwood ligament provides a pulley effect and acts as the functional origins of the inferior oblique and the inferior rectus muscles. The neurovascular bundle containing the nerve to the inferior oblique is attached to this pulley, as we have already mentioned, and since the Lockwood ligament is attached to the lower eyelid through the capsulopalpebral fascia, recession and resection of the inferior rectus muscle can result in depression and elevation respectively of the lower eyelid, and this is very important to remember. The portion of the muscle from its pulley to its insertion determines the direction of pull of the muscle, and the portion of the muscle posterior to its pulley is the main force generator but does not determine the direction of its pull. When the eye moves into secondary and tertiary gaze position, the direction of pull of the rectus muscle changes, and this change in direction of the pull of the rectus muscle is half the angle of the gaze position from the primary position. Heterotopy or malposition of the rectus pulleys can change the direction of action of the rectus muscles and resemble oblique muscle dysfunction. This heterotopy or malposition of the rectus muscle pulleys can occur due to bony abnormalities such as craniosynostosis or age-related laxity of connective tissues, as found in sagging eye syndrome and adult onset esotropia. A-pattern strabismus has been shown to be caused by higher position of lateral rectus pulley as compared to the medial rectus pulley, and V-pattern strabismus has been shown to be caused by lower position of the lateral rectus pulley as compared to the medial rectus pulley. Pulley damage can be caused by posterior dissection during surgery and may result in concomitant strabismus. Also, the pulley system reduces the effectiveness of muscle transposition surgery. The extraocular muscles are designed to provide speed of contraction, sustained action, and fatigue resistance. Most muscle fibers are long, acting end-to-end with little lateral interactions. Extraocular muscles are structurally similar to skeletal muscle fibers, but the nerve to muscle fiber ratio is 10 times higher as compared to conventional skeletal muscle fibers. A predominant majority of muscle fibers in extraocular muscles are singly innervated, that is, a single motor nerve supplies only a single muscle fiber. This allows extremely precise control of muscle fibers according to their specific insertion location on the sclera. Within each rectus and oblique muscles, there is compartmentalisation of muscle fibers according to the location of insertion of the muscle fibers and the nerve supply to the muscle fibers. According to the location of the insertion of the muscle fibers, each extraocular muscle has a global layer and an orbital layer, and electromyography shows differential responses from these two layers. The global layer passes through the connective tissue pulleys and inserts on the sclera, providing oculorotatory function, and the orbital layer inserts on the pulleys, thus retracting the pulleys along the muscle axis when the muscle contracts and fine-tuning the position of the functional origin of the muscles at the pulleys. For rectus muscles, the orbital layer lies towards the orbital wall as shown by the light brown areas in these diagrams, and the global layer lies towards the globe as shown by the dark brown areas in these diagrams. For the oblique muscles, the orbital layer lies concentrically all around the external surface of the muscle, and the global layer lies in the center as seen here in these two diagrams. For the superior oblique muscle, the orbital layer passes through the trochlea and attaches to the nasal aspect of the superior rectus muscle pulley as shown here in this diagram, and thus contraction of the orbital layer of the superior oblique muscle pulls the superior rectus muscle pulley nasally. For the inferior oblique muscle, the orbital layer is attached to the nasal aspect of the inferior rectus pulley and the inferior aspect of the lateral rectus pulley as shown here in this diagram. So the contraction of the orbital layer of the inferior oblique muscle pulls the inferior rectus pulley nasally and the lateral rectus pulley inferiorly. Also, contraction of the inferior rectus muscle pulls the inferior oblique muscle pulley posteriorly. And so far as the muscle fibers themselves are concerned, the global layer has red, intermediate and white fibers, and the orbital layer has only red fibers. The red fibers having the highest concentration of the mitochondria and thus being the most fatigue resistant as well as most susceptible to hypoxia. The orbital layer, being the more fatigue resistant, is more suited at providing sustained pulley tension. In addition to the compartmentalization of muscle fibers based on their insertions, there is also a compartmentalization of these fibers based on the innervation of these muscle fibers across their insertion on the globe. And this compartmentalization is transverse and occurs in the rectus and superior oblique muscles, which subserve differential pull of the muscles along the width of the tendinous insertions. Each horizontal rectus muscle has an upper and a lower transverse compartment supplied by two separate branches of their respective supplying nerves. For the inferior rectus, the entire insertion is supplied by one branch of its motor nerve, with an additional supply for the lateral compartment of its insertion by another branch of this motor nerve. The trochlear nerve divides into a medial and a lateral branch to supply two compartments of the superior oblique muscle. The lateral compartment of the superior oblique muscle attaches posterior to the equator and provides predominantly infraduction action, and the medial compartment of the superior oblique muscle attaches at the equator and provides predominantly encyclotorsion action. This differential innervation of the superior oblique muscle is the basis of the Harada-Ito procedure, which is done for patients with superior oblique muscle palsy to enhance the encyclotorsion action of the medial compartment of the superior oblique muscle. The lateral muscular branch of the ophthalmic artery supplies the lateral rectus, superior rectus and the superior oblique muscle, and the medial muscular branch supplies the medial rectus, inferior rectus and inferior oblique muscles. Additional supply to these muscles include lacrimal artery supplying to the lateral rectus muscle and the infraorbital artery to the inferior rectus and the inferior oblique muscle. The lacrimal artery originating from the ophthalmic artery and the infraorbital artery originating from the external carotid artery. What is important to remember is that the arteries to the four rectus muscles provide the anterior ciliary arteries 1 to 4 in number in each rectus muscle. The anterior ciliary arteries provide blood supply to the anterior segment, Almost all of the temporal half of the anterior segment and part of the nasal half of the anterior segment are supplied by these anterior ciliary arteries originating from the arterial supply of the rectus muscles. These anterior ciliary arteries enter the sclera just anterior to the rectus muscle insertion and anastomose with conjunctival vessels at the limbus and ultimately join the major arterial circle of the iris. Thus, conjunctival blood vessels also have a minor supply to the anterior segment, and it is very important to remember that simultaneous surgery on 3 or more rectus muscles may cause anterior segment ischemia, particularly in elderly patients. However, arteries to oblique muscles do not supply the anterior segment. The venous drainage from the extraocular muscle follows the arterial supply and drain into the superior and inferior orbital veins. The vortex veins are closely related to the extraocular muscles, but they themselves do not drain the extraocular muscles. The vortex veins can be found located adjacent to the nasal and temporal margins of the superior and inferior rectus muscles. The superotemporal and the inferotemporal vortex veins, as shown here in this diagram, are consistently located along the posterior margins of the superior and the inferior oblique muscles, and surgery on these superior and inferior oblique muscles may injure the vortex veins. The tenon capsule is a fibroelastic membrane forming the principal fascia in the orbit. The blue line in this diagram represents the tenon capsule. With a smooth inner surface, the tenon capsule provides a space within which the globe rotates, and the tenon capsule extends from the optic nerve posteriorly to the sclera 3 mm behind the limbus anteriorly. The tenon capsule fuses posteriorly with the optic nerve sheath, and anteriorly it fuses with the conjunctiva near the limbus. Posteriorly, the tenon capsule is thin and allows movement of the optic nerve, ciliary nerves and ciliary vessels when the globe rotates, and the posterior portion of the tenon capsule separates the intraconal fat from the globe. Near the equator, the tenon capsule becomes thick as seen here in this diagram and attaches to the orbital fascial connective tissue, thereby suspending and supporting the globe, which is called its trampoline effect. The rectus muscles enter fascial slings of the tenon capsule as seen here in this diagram, approximately 10 mm posterior to their insertions. At the juncture where the rectus muscles enter the tenon capsule is thickened to form pulleys for these muscles, as we have described previously. Anteriorly, the two oblique muscles enter the tenon's capsule, and the tenon capsule here separates the extraconal fat from the globe. Adipose tissue or fat in the orbit supports the globe, and the adipose tissue in the orbit is divided into two regions, the extraconal or the pre-aponeurotic fat pad and the intraconal or the retroocular fat pad. These two regions are separated by the rectus muscles and the intermuscular septum between the rectus muscles. The extraconal fat pad extends anteriorly up to 10 mm behind the limbus, and the intraconal fat pad is separated from the globe by the tenon capsule. During extraocular muscle surgery, the tenon capsule should not be violated 10 mm posterior to the limbus, because this will result in fat prolapse, which can form restrictive adhesions to globe, extraocular muscles, fascia and or the conjunctiva, resulting in restriction of eye movements. To summarize, there are 7 extraocular muscles, 4 rectus muscles, 2 oblique muscles and 1 levator palpebris superioris muscle for each eye. The rectus muscles originate from the annulus of Zinn and insert anterior to the equator of the eye, with the distance of their insertions from the limbus being 5.5 mm for the medial rectus, 6.5 mm for the inferior rectus, 6.9 mm for the lateral rectus and 7.7 mm for the superior rectus. The superior and inferior rectus muscles are oriented 23 degrees to the visual axis in the primary position of the eye. The sclera is the thinnest posterior to the insertions of the rectus muscles. The superior oblique muscle rises from above the annulus of Zinn, travels forward towards the trochlea, is redirected posterolaterally by the trochlea, and inserts on the superotemporal aspect of the globe behind the equator of the globe. The inferior oblique arises from the anterior portion of the floor of the orbit and travels posterolaterally to insert on the posterolateral portion of the globe near the macula behind the equator of the globe. The obliques are oriented 51 degrees to the visual axis in the primary position of the eye. The fourth cranial nerve supplies the superior oblique muscle. The sixth cranial nerve supplies the lateral rectus muscle. The superior division of the third cranial nerve supplies the superior rectus and the levator palpebris superioris muscle, and the inferior division of the third cranial nerve supplies the inferior rectus, the inferior oblique, and the medial rectus muscles. The Tenon capsule extends from the optic nerve sheath posteriorly to 3 mm behind the limbus anteriorly. Near the equator, where the muscles enter the Tenon capsule, the Tenon capsule is thickened to support the muscles, and this is called the Pulley system, which are considered to be the functional origins of the muscles. The fibres in the muscles are compartmentalized into orbital fibres, which insert into the pulleys and can alter the position of these pulleys, and global fibres which insert into the sclera and is responsible for movement of the eye. In addition, there is also a transverse compartmentalization of fibers in a muscle, with each compartment being supplied by one of two branches of the motor nerve of that muscle. During extraocular muscle surgery, violation of Tenon's capsule 10 mm posterior to limbus may result in orbital fat prolapse, which may lead to restrictive adhesions. Anterior ciliary arteries originating in the rectus muscles provide the major blood supply to the anterior segment, so simultaneous disinsertion of 3 or more rectus muscles can result in anterior segment ischemia. Thank you for listening.